Hello, and welcome. Today we're shedding light on a serious but often overlooked complication of radiation therapy, radiation-induced cardiomyopathy, or RI-C. We'll explore what it is, how it develops, and what can be done to manage and potentially prevent it. RI-C is, as the name suggests, damage to the heart muscle caused by exposure to ionizing radiation. This is most commonly seen in patients who have received radiation therapy as part of cancer treatment, particularly for cancers located in the chest, such as breast cancer, lung cancer, lymphoma, and esophageal cancer. The heart, even if not directly targeted by the radiation beam, can still be exposed to scatter radiation, leading to long-term damage. Factors like the total radiation dose, the fraction size, and the specific areas of the heart exposed all play a role in the likelihood and severity of RI-C. It's also important to note that pre-existing cardiovascular risk factors, like high blood pressure or diabetes, can increase susceptibility. The pathophysiology of RI-C is complex and involves multiple mechanisms. Initially, radiation causes acute inflammation and oxidative stress within the heart tissue. This triggers a cascade of events, including damage to the small blood vessels, the capillaries within the heart muscle. This is called microvascular dysfunction. Over time, this can lead to fibrosis, or scarring, of the heart muscle, making it stiffer and less able to pump blood effectively. Additionally, radiation can damage the heart valves, the pericardium, the sac surrounding the heart, and even the electrical conduction system of the heart, leading to arrhythmias. This cumulative damage ultimately impairs the heart's ability to function properly. The exact prevalence of RI-C is difficult to pinpoint because it can develop years, even decades, after radiation therapy. Estimates vary widely depending on the radiation techniques used, the follow-up period, and the specific population studied. However, it's increasingly recognized as a significant late effect of cancer treatment, especially as survival rates for many cancers improve, leading to a larger population of individuals at risk. Modern radiation techniques aim to minimize cardiac exposure, but awareness and vigilance remain crucial. The signs and symptoms of RI-C can be subtle and often mimic other forms of heart disease. Patients may experience shortness of breath, especially with exertion fatigue, chest pain, swelling in the legs and ankles, and palpitations or an irregular heartbeat. Because these symptoms are nonspecific, RI-C can be easily overlooked, particularly if the patient is also experiencing other late effects of cancer treatment. It's important for cancer survivors to be aware of these potential cardiac issues and report them to their healthcare provider. Diagnosing RI-C can be challenging. It typically involves a combination of non-invasive and sometimes invasive tests. An electrocardiogram or ECG can help identify arrhythmias or conduction abnormalities. An echocardiogram uses ultrasound to assess the structure and function of the heart, including valve function and the heart's pumping ability. Cardiac MRI is useful for detecting fibrosis and inflammation. In some cases, a cardiac catheterization, an invasive procedure where a thin tube is inserted into a blood vessel and guided to the heart, may be needed to measure pressures within the heart and assess coronary artery disease, which can coexist with RI-C. A thorough history, including details of prior radiation therapy, is essential for making the correct diagnosis. While RI-C doesn't have specific subtypes in the same way some other heart conditions do, its manifestations can vary. It can present as heart failure, where the heart can't pump enough blood to meet the body's needs, valvular heart disease, affecting the heart valves, pericardial disease, such as pericarditis or constrictive pericarditis, coronary artery disease, where the arteries supplying the heart are narrowed, or arrhythmias. The specific type of damage will influence the treatment approach. The treatment and management of RI-C focus on alleviating symptoms, preventing further heart damage, and addressing any underlying cardiac issues. This often involves medications commonly used for heart failure, such as ACE inhibitors, beta blockers, and diuretics. Anti-arrhythmic medications may be needed to control irregular heartbeats. In some cases, surgical interventions, such as valve repair or replacement or even cardiac transplantation, may be necessary. Lifestyle modifications such as a heart-healthy diet, regular exercise, and smoking cessation are also crucial. Prevention is paramount. Modern radiation techniques like intensity-modulated radiation therapy as IMRT and proton therapy are designed to minimize radiation exposure to the heart. Deep inspiration breath hold techniques can also help move the heart out of the radiation field during treatment. Early detection and management of pre-existing cardiovascular risk factors, such as high blood pressure and diabetes, are also essential for more. Some studies are exploring the potential role of cardioprotective medications during radiation therapy to reduce the risk of RI-C. The prognosis for patients with RI-C varies depending on the severity of the condition, the presence of other medical problems, and the effectiveness of treatment. Early diagnosis and intervention are key to improving outcomes. Recent research is focusing on identifying biomarkers that can predict the development of RIC and on developing novel therapies to protect the heart from radiation damage. For example, studies are exploring the potential of anti-inflammatory agents and antioxidants to mitigate the effects of radiation on the heart. Continued research is crucial to better understand, prevent, and treat this challenging late effect of cancer therapy. Thank you for joining us in learning more about radiation-induced cardiomyopathy.